Hey y'all, my name is Maddie Cheever. I'm a registered dietitian nutritionist, certified health education specialist, type 1 diabetes specialized coach, and the face and founder of Type 1 Type Fun. And I also live with type 1 diabetes. I share stories, resources, and tips to make diabetes management easier and a lot more relatable and fun. And on today's show, I'm speaking with Dr. Larry Deeb, pediatric endocrinologist, faculty member at Florida State, and former president of the American Diabetes Association. Dr. Deeb has seen diabetes care evolve a lot over the last 40 years. We chat about all the ways treatment has improved and why he says early screening and prevention are so important. Okay, so let's jump in. So, if you don't mind me asking, you've been practicing for more than 40 years, right? So, you have seen treatment change drastically throughout your career. Can you tell us a little bit more about how it has changed or how much?
Sure. And interestingly, I can go all the way to yesterday, or actually at the end of last week. When I started taking care of children with diabetes, we managed by having them go to the bathroom, show me a glucose test for the urine, and then giving them insulin. You can imagine how inaccurate that was. Just nuts. And yet we doing the state of the art. And eventually we got to do blood sugars at home with meters, and then some got memory. And then we did the DCCT where we proved control works, and then we were stuck really trying to do it. And now we're all the way to automated insulin delivery with really smart pumps, but even bigger than that, we're into trying to prevent diabetes. We know it's autoimmune. And last week, I got to 18 months with the first child, and I might argue I prevented my first case of type 1 diabetes. Can you even imagine how emotional that is for a doctor?
Beautiful. That's amazing. Congratulations. Congratulations. That is incredible. And if you're willing to share, I'd love to know more details.
So we participate in what's called TrialNet.
Mhm.
And because of that, we ask siblings of cases of T1D to be screened. He, amongst lots of others, well, for virtually all others, you ask. And he came back to the office, that is the child with diabetes, and his brothers, and those brothers got screened. One of them had 4 antibodies. So then you begin looking at how's his blood sugar going? And you notice it begin to go up. A1C got to 6.6, which is right at the break point of diabetes. We intervened. 18 months later, his A1C is 5.4. That's not diabetes. So we'll see. The word prevent implies really long term, but you can only go day by day. So, and I wouldn't use the word prevent if it weren't 18 months. So,
Absolutely. Wow. And TrialNet is a resource that I believe that it's something I've talked about online for sure several times, and I'll make sure that there's some info down below for those who are interested. The very essence of what we're discussing here is getting tested to double check what's going on in our system if we are connected to a loved one with type 1. So if you have a loved one with type 1, or if you are type 1 and have a sibling that, who knows, maybe you'll love them, that would be some good information to share. So we'll make sure it's down below. And thank you for talking about all of that. It's just so incredible to see the progression of diabetes in practice, in management, and I'm really excited to see what comes up. And actually, there's another question that I have for you. So, first of all, I know that you served as the American Diabetes Association president and for an organization called Life for a Child, which, if I'm correct, supplies insulin and other diabetes tools to children in low resourced countries. What are some of the lessons that the US health system could potentially learn from other countries?
first of all, when I was president of ADA, that was the year that the United Nations approved the resolution to create World Diabetes Day. A whole lot of people were involved. It was fun to be in New York for that event at the UN. Life for a Child grew out of the recognition that the most common reason children die from diabetes around the world is lack of insulin. So 25 years ago, hard to believe, we're celebrating our 25th anniversary. I'm also a very active Rotarian, and using 3 Rotary Global grants, we were able to get supplies to children and show, hey, you could teach people to manage it. B, establish clinics. You don't just hand out supplies. It's got to be treated. And work with doctors to improve care. And then C, guess what? Children live. And over the decades, the numbers, of course, have increased. And we've worked with the doctors doing projects to improve care. And interestingly, we're now even going to try to work on ways to get continuous monitoring. But I think the question you ask is, what could we learn? Working together, that is with the patients, with the community, we can improve care. And you have to make commitment to it. As a center, you can't just see someone and let the status quo run. You have to push.
Absolutely. I agree with collaboration completely as well. I think the more we are able to bring our minds together, bring our knowledge, our education, our backgrounds together and move forward, that is, I think, ultimately the most productive path. So I love that and I appreciate you sharing that. And I feel like from everything I'm hearing from you so far, it's clear to me that you have been a very prominent part of the history of diabetes, and in my mind, a little bit of a trailblazer. And something that I know that you have also worked on is clinical studies of insulin and diabetes, maybe diabetes devices. Tell me
Yeah.
more.
A physician lives where he or she does and takes care of, in my case, children where she is working. And I felt it really important that children I cared for could have access sooner rather than later to things. And so I even tell people, and it is the truth, because I was actively pursuing some of the newer insulins, the very first child on earth got it from me. And all of them, you know, Insulin Lispro, Humalog, Lantus, Novolog, Fiasp now, Insulin Degludec, Tresiba. We did those trials, and children received insulin and care and learned to do it. Likewise with the continuous monitors and pumps. And again, early access. And I'm going to start a study using a pill to maybe prevent diabetes. That's coming along. And I really, really want to give the first kid on earth that pill.
Oh my goodness. I hope you're able to. Absolutely. Wow, you've touched so many aspects of when I think about my own life even, all of the things that I have to do. This morning, my insulin pump ran out of insulin. What did I have to do? I had to get insulin. I shifted to a new insulin. I had to get my insulin pump sorted out. I switched to a new infusion set, and all of these things, they may be almost minimal, but they can have a huge impact. I'm noticing my blood sugar looks just a little bit different with one of my typical meals today compared to me eating it a few days ago, and maybe those are contributors. So the fact that you have had such a hand in the journey of all those things is just I got goosebumps when you were speaking earlier. It's amazing what you have done and are doing. And I think a lot of the times when I'm talking to a lot of folks, people will ask like, how do you know all the things? How do you keep up with all the things? And the answer is I don't. I don't know all the things. I don't I can't keep up with all the things. But do you have any advice to anyone, patients, providers on how to keep up with all of what's happening, whether it's devices, medications, anything like that?
So it really does turn out that you have to decide as a doctor what you want to be, um, because you really can't know everything. But you can have ways to get it fit to you. Here at the FSU Medical School, we have access to thousands of electronic resources. And so every Monday, I get this feed, and a medical student will come in and I say, I wonder what's new this week in the New England Journal of Medicine. The operant word is curiosity. Curiosity. And then I make my patients, and I tell them to do this to me. So why do I make you come see me? And they go, "But da, 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 da." I said, no, 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 no. You come see me because you pray I'm smarter than the last time. And I've had, why is that like teenagers come in? Are you any smarter this time? And I hope I am. And I hope I am. And so I think that kind of, for me, is what keeps me pushing forward because the people are pushing me, pulling me.
Yeah.
Yeah.
Absolutely. Absolutely. I think having it sounds like there's a little bit of an intrinsic and an extrinsic factor there. And I think the combination of both can
Mhm.
be a really incredible way to go about it. And I jumped in my thoughts here. I had another question for you if you're okay with it.
Of course.
When we were talking about the auto antibody testing, that's some of the TrialNet information for anyone who was paying attention at that section. Uh, we could detect those autoantibodies potentially years before onset, correct?
Yes.
Okay, and so here's my question then, is from your perspective, what is a realistic timeline for potentially preventing type 1 diabetes?
Well, I think we're going to learn that.
Okay,
Presently, the standard is when the blood sugar starts to move up. That's the standard because we know that everybody who gets antibodies doesn't get diabetes. That's important. And when you say to a family, 1 in 400 has diabetes in the United States, kids. So the new kid, 6-year-old in the hospital last night, no way I could have known or prevented. Okay? Because we're not screening everybody. Someday, but not today. But
okay,
if 1 out of 15 siblings, then it's worth screening. And also, you have them captured. I mean,
okay.
you're taking care of the kid so you can talk to the family.
Yeah,
But that means 14 out of 15 don't. A woman who asked me, should I have children? I have T1D. What's the chance? I answer the right way. 97 out of 100 babies don't get diabetes. Have your kids if you want. Um, so everybody doesn't. And so you don't want to put powerful medicines in somebody who doesn't need it. And so today we wait to see the movement. Someday we'll maybe know they're going to move sooner rather than later.
okay. That actually brings up another thought I have too then, and so, one of those signs that you mentioned is the uptick of blood sugar, and so I'm curious to kind of just bring a little bit of context to this conversation. We're talking about type 1 primarily, but when it comes to type 2 diabetes, we know that there have been more young adults or children even, being diagnosed. What are some of those potentially overlooked early signs, if you know, that we should be acting on sooner, and does that differ?
So, one, Prediabetes is a big part of obesity.
Okay.
Not diabetes yet, pre. So the question in these overweight children isn't, and prediabetes is defined as an A1C between normal and it's lab dependent. So if I give a number, the other lab would be wrong. There's a normal and there's a diabetes, and there's a distance between them. Prediabetes. Look, because by the time, so I'll see somebody with slightly abnormal A1C and overweight, and you begin to work at it, and you look at to make sure they're not antibodies. It's not really an overweight kid with early T1D, but they don't have antibodies, they don't have diabetes. Then I remind them getting up in the night to go to the bathroom means things have fallen apart. But even then, you don't want them to end up in the ICU. So therefore, you're doing, that catch me before I fall off, but monitor to see where it's going, and it become a encouragement to see the A1C had been a number and be a number that's lower. In other words, trying to prevent the development of type 2.
Okay. So if I can summarize just a few things from maybe what I'm hearing from you, it sounds like we can't just assume, right? Diabetes, which we already know this, but for anyone listening, we can't just assume type 1 or type 2. There are some specific symptoms that are associated with one or the other, and maybe a little overlap depending on how the blood sugar is playing out or what's
Mhm.
happening. But these are very different diseases. There's some overlap, similar, different, but maybe that's what we could talk about a little bit more is differences in type 1 and type 2 and maybe how it should be approached. Mindset, treatment, lifestyle, monitoring, you name it. What should we know?
Right. So I would argue type 2 diabetes in a young person is a worse disease than type 1. Wait a minute, Dr. D. What if you can control them with medicines and this? If you look at the Today trial done and published, it's well over 10 years ago now, and they followed some of those children out. Heart disease, kidney disease, difficulties with pregnancy, all of those things were just rampant in type 2 diabetes. So you really want to prevent it. I mean, do the very best you can to know the risk, and overweight's the biggest start sign to prevent it. Um, and then when not, to manage it. And truthfully, it is a condition that presents itself more in minority children. And therefore, frequently in that group, the social determinants of health are really, use the word, against them. So when you're worried about housing or food or these kinds of things, some of the other stuff related to health and is just harder to be on the front burner.
Absolutely. Absolutely. And if you're listening and you are actively considering going into healthcare, or maybe it's of interest, or you just want to know a little bit more, the social determinants of health, I think, can provide a pretty good, or at least a starting point for a little bit more perspective on some of the factors that we look at that aren't necessarily biological markers, for example. So hearing that keyword, I really appreciate you saying that and bringing some
Yeah,
context there.
it's just critical when you're caring for people to know the whole story. You know, this is
Of
the
course.
second child in a SIV ship, and the one that's a year younger has Down syndrome, or the one that's a year younger has profound autism, and they're struggling, every day financially. You don't blame the victim then.
Yeah, absolutely. And from what I'm hearing from you, which I very much appreciate, is you are prioritizing perspective, you're prioritizing collaboration, you are prioritizing seeing people and and helping them the best way that you possibly can. And unfortunately, I do believe that especially now and previous and probably still in future, there are some folks receiving care from people who maybe don't align with those beliefs or practices, right? Who aren't collaborative, who are not going to try their best to be a wonderful, kind provider, whatever it may be. If someone finds themselves in that position and they don't feel like maybe something's off, would you recommend anything to that person?
The each one of us practices in an environment that's unique to them, and I'm incredibly blessed to have wonderful educators, wonderful dietitians, and a dedicated social worker who visits every new child with diabetes, gets to know them, and explores, and then comes report to me, so that you know if what we can do together to do the kind of care they need, and everybody doesn't have that, and I know that. So and everybody doesn't be be able to say to a patient or someone, call Kim, or have access to um, you know, the entire population's continuous monitoring. I don't look at it. But if you call me, I can look at it.
Yeah,
It's important here. No, Dr. Deeb is not monitoring 600 children's sugars every day. But if mommy's concerned, I can get concerned, or the educators can get concerned.
yeah,
And so that kind of, you know, those things in practice, and even the mom who's having trouble, you know, issues that are more social than medical, you can then point them in directions that they may not have thought of.
yeah. Okay. So if you're listening and you feel like maybe you're not being pointed in those directions, maybe it's worth asking some of those questions. And if those answers are provided, maybe there is a different provider that will suit you best. Everyone is different. Every patient, every provider. We are all humans, and we try our best with what we can, and we keep going. So hopefully everyone's well taken care of. But if not, know that there's someone out there for you. And
Absolutely.
yes, and I think that the other question that comes to mind is we've talked about so many things that have and are happening, but what do you anticipate will happen, let's say in the next 5 to 10 years of diabetes medication technology? Is there anything you think is going to maybe really take a turn?
So the standard of care today for me is getting children as quickly as they're willing. It's patient centered, but as quickly as they're willing. And if the younger they are, you push even harder. For me, the standard of care today, you know, I had once had this run of 3 2-year-olds in the same month, but all 3 2-year-olds on automated insulin delivery pumps within weeks of diagnosis. So my goal for children with diabetes, and I say it out loud, is to help you live with it instead of for it. And the more these things come together, the more it allows you to do that. Um, and I think that's going to be where the technology moves, where you set it and forget it. And it's coming. And can you even imagine those days? Well, you still have to change the pump out, still have to change the side out. I mean, it's not going to be, but in between, if you can go 2 or 3 days with it sort of doing its thing, that's coming.
Oh.
We're marching in that direction.
Oh my goodness. Okay, I got goosebumps again. With it, not for it might be my favorite quote of the day. And the fact that you just said that too, a conversation I was having actually yesterday with one of my clients is the fact that diabetes type 1 does not get a day off. There's not a day where we can just not, or maybe if that happens, there's usually quite a few consequences. But to hear you say that maybe that could be a potential is to be able to minimize a lot of the work or even have a little bit of that, flexibility here and there.
Well,
Oh, what
I mean, realistically, you're gonna have to mind. But minding is one thing. You know, oh, the blood sugar is staying fine. It's staying fine. I'm b and now the fancy pumps, I'm about to eat, let me just tell it I'm gonna eat,
Mhm.
and, that's dramatically different than just a few years ago where
Yeah.
you had to do all this math and do all this help because they weren't integrated. I mean, the number of times a day you touch diabetes 5 years ago, 10 years ago, and today can be dramatically different. I didn't say ignore it, touched it. So I mean, I have children now whose touching of diabetes is best estimate of carbs before meals,
Mhm.
period, period.
Yep.
The automated parts of it do the rest.
Yeah.
And trust me, finger pricking and giving shots, you touch diabetes, even if it's well done. And the greatest gift I tell patients isn't to the child, it's to mama.
Oh,
She sleeps at night.
oh, yeah. Oh, yeah. I know all my moms would hear that and be like, "Woo, yes, thank you. That's all I want." Oh, that is, incredible, and something I say a lot is that so for everyone here who is usually a listener, they know I'm a professional diabetic, right? I am type 1, but
Yeah.
I also work in this space. I have years of education, years of food tracking, years of data analysis, years, so many years, and here's the thing, I am also human, I still make mistakes here and there, I don't have perfect blood sugar, and I just sometimes it's hard for me to even recall even like a decade ago where younger Maddie was, where what younger Maddie didn't know, what younger Maddie just could not possibly have understood. Thinking about the past is like, wow, how far I have come. But thinking about the future, I don't think that we have to be professionals to be able to really manage well. And I'm so excited about that.
And let me throw this out.
Okay.
Okay, where did all the time and range stuff that you see on the Dexcom, on the Libre, on the all the pumps outputs, where did that come from? That came from decades of observing people with diabetes from the 1983 cohort of the DCCT, followed out to 2018. And we looked at complications. And we looked at the blood sugars in those groups because they were saints, I mean to tell you. And it's not 100%. The time and range comes from those data. And if you're achieving good time and range, oh, Dr. Deeb, that means some of the blood sugars can be over 250. Yes, not a lot, but some. You want the most. That also can take some of the pressure off of people who have T1D.
Oh, yeah.
The child comes in 2% over 250, 82% in range, which is well above the needed time in range. And you look at them and say, how long you plan to live? And they look at you. You go, try 90. I mean it. Try 90. And it's not all blood sugar is 100. Doesn't have to be.
Yeah.
Well, it can be, but it doesn't have to be either.
Yeah.
I didn't say, I'll see somebody who's in really good time and range that I have more experience, and I say, you might want to try A and B and see if that doesn't help. So it's not that I'm not working to do and be as good as we can get, but it's never going to be perfect.
Oh, it will never be. And that, thank
It
you.
doesn't have to be.
Thank you for saying that. It's not gonna be perfect for those listening. It's never gonna be. It's not about perfection. It's about intentionality. It's about living your life and also managing, right? Not with,
Mhm.
not for. With, not for. I love that. Oh, man. It is, and something actually that I get a question on a lot, especially for maybe those who are newly diagnosed or maybe a little more concerned about blood sugar things. They expect this straight line to happen with their blood sugar. That's what they go for, right? And well, what I tend to tell them, I'm like, I don't know how to tell you this. Well, I do know how to tell them, but I say, I don't know how to tell you this. Even people without diabetes don't have that,
No,
right?
no.
And it puts it into perspective just a little bit.
Yes.
It's not perfect for someone with diabetes. It's not perfect for someone without. We all do our best. Some of us have to do that manually. Other people's bodies do that for them. We make it work.
Hmm.
I love this. I love this. Is there anything that I haven't asked that you wish you had a moment for listeners to hear?
Well, we've done pretty well. I
Yeah.
So do you sense my optimism, my
Yes.
enthusiasm at sort of what we're able to do, the enthusiasm and optimism that we're able to help so much, and you can be successful and you can be healthy and you can be playing the NFL or Major League Baseball or, and looking at you, if you want 3 kids, have 'em.
Yeah.
You get to
Yeah.
pay for it, but that's
Oh,
fine.
yeah. Yeah.
Trust me, I have.
Yes.
But nevertheless, live a nice, healthy life.
Yes. Yeah, you can do anything. I think the only things that are technically still not necessarily full T1D proof are space travel and super deep sea diving. Maybe the deep sea has changed. I don't think space has,
Not super
but
sea, deep sea, no.
okay. Yeah.
Not. But 50, 60 feet's enough. You can get down among the critters
Yeah.
and enjoy life.
Yeah.
Yeah.
Yeah. And there's
And I've
a
had super certified kids for T1D. Yeah.
yeah. And I think there's a lot of opportunity and potential if you have the creativity and are willing to put in a little of the work to figure it out. Even when I get basic nutrition questions, they'll be like, "Oh, well, what would I eat for this?" We really just need creativity. Well, could you have that? Could you have that? Could you have that? It's not really about what you can and can't eat. It's just about
Mhm.
what and how. And thank you for your positivity today. I definitely felt it. Your hope, the inspiration. I mean, you've provided me inspiration. I got goosebumps twice on this thing, okay? I don't usually get goosebumps, so thank you for the goosebumps. It's such a privilege and such an honor to get to have this conversation. I really appreciate it. I hope everyone listening feels so hopeful as well. And I guess with that, we will see you all on the next episode. But Dr. D, thank you for
My
bringing things
privilege.
over.
My sincere privilege. Thank you.
That's it for today, my friends, but the fun doesn't stop here. If you liked this episode and want more real talk diabetes support, come hang out with me on social. Just search Type 1 Type Fun, all words, or head to type1typefun.com for tools, tips, freebies, and real life resources you can actually use. And if this episode made you laugh, learn, or feel a little more seen, feel free to leave a comment, give it a like, share it with someone you love. But until next time, live empowered, be silly, have fun, and eat some carbs.
The information shared on this podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast.